So now let's discuss the laboratory investigations of the asthma. These include the ABGs, spirometry, bronchoprovocation test or methacholine challenge test, peak expiratory flow meter, and additional tests include the chest radiographs, total serum Ig level, and allergen specific Ig levels. Now, first of all, come to the ABGs. ABGs in mild asthma exacerbation, the ABGs will be normal, and but there may be respiratory alkalosis and an increase in the alveolar arterial oxygen difference. During severe exacerbation, hypoxemia develops and the PaCO2 returns to normal. While the combination of increase in the PaCO2 and respiratory alkalosis may indicate the respiratory failure and need for mechanical ventilation. Other tests include the spirometry, that include the forced expiratory volume in 1 second and forced vital capacity and ratio of the forced expiratory volume vital capacity before and after the administration of short-acting bronchodilators. Airway obstruction is indicated by a reduced FE1 and FC ratio, generally below 0.7, and significant reversibility of the airflow obstruction is defined as increase of about 12% or more and 200 ml in FE1 or FEC after inhaling the short-acting bronchodilators. Severe airflow obstruction results in significant airway trapping with an increase in the residual volume and consequent reduction in the forced vital capacity, resulting in a pattern that mimics the restrictive ventilated effect. Now come to the bronchoprovocation test. With inhaled histamine or methacholine may be useful, and when asthma is suspected, but the spirometry is non-diagnostic. A positive methacholine test is defined as a fall in the FE1 of 20% or more at exposure to the methacholine concentration of less than or equal to 8 mg per ml. Now come to the peak expiratory flow meters. These are the handheld devices that are designed as a personal monitoring tools. Peak expiratory flow monitoring can establish peak flow variability, quantify asthma severity, and provide both patient and clinician with subjective measurements on which to base the treatment decisions. Peak expiratory flow show diurnal variation. It is generally lowest at first awakening and highest several hours before the midpoint of the awakening. Peak expiratory flow values less than 200 liter per minute indicate severe airflow obstruction. Additional testing, chest radiograph are usually normal or may show the hyperinflation. Other findings include the bronchial valve thickening and diminished peripheral vascular markings. Chest imaging is indicated when the pneumonia, another disorder mimicking asthma or other complication of the asthma such as pneumothorax is suspected. Total serum Ig levels and allergen specific Ig levels are done to assess the sensitivity to environmental allergens, can identify atopy in patients with persistent asthma. Evaluation of the paranasal sinuses and GERD should be considered in patients with persistent severe or refractory asthma symptoms, and absolute eosinophil count can be done for the patients to identify whether the patients are eligible for the interleukin-5 therapy to manage the eosinophilic airway disease.